I would just like to start exactly why did I use this particular background of a PPT. This particular hiker, I feel, is one of the gynecologists who's really trying and fighting against nature, trying to treat a woman with endometriosis. Determined, very focused. And the moment they reach one particular peak, they feel the patient has really become better and they're so happy. But the moment they reach the peak, they find so many more peaks ahead. And the trial and the difficulties tend to continue. And that is what endometriosis is basically all about. It's a chronic progressive disease. We treat one factor and we're there ready to treat the other one. And that is what leads us to a lot of dilemmas. So relationship between the two is very intricate. Endometriosis affects about 10 to 15% of women in reproductive age. Of women with endometriosis, 30 to 40% have infertility. And those who have infertility, about 25 to 50% have endometriosis. It is found that infertile women are at 6 to 8 times more likely to have endometriosis than a fertile woman. But the silver lining is that although endometriosis impairs fertility, it does not usually prevent conception. And that is why we are all here to discuss about the fertility issues along with endometriosis. I'm going to be basically taking with some few case discussions. Some Dr. Nymphia has done, but maybe we'll just go through them again. And the reason is that as a gynecologist, every day when we sit across the table with the person with endometriosis, we have to make clinical discussions. And these decisions are extremely difficult because they have not been very well evaluated with the various RCTs, and the observational data are somehow insufficient in helping us to make confident conclusions. So coming straight to some of the cases that we deal daily. She's a 30-year-old girl, primary infertility for last 2 years. On taking a detailed history, we came to know that she has mild dysmenorrhea, which has been there for the last about 10 to 15 years. She's very well managing with the NSAIDs. Quality of life is well maintained. We evaluated her for all of the factors of infertility and we did not find any abnormality. So the question that comes to our mind or the suspicion is that maybe she has stage 1 or 2 endometriosis. The question we need to actually ask ourselves, should I offer her laparoscopy?
Dr. Jyoti, please usko hide kar do. Niche slide sharing pe.
Slide
cover karta aapke.
Okay.
Thank you.
So the question that we all need to think at that particular moment, yes, I'm suspecting her to have stage 1 and 2 endometriosis. Should I offer a laparoscopy both for the diagnosis as well as for the treatment? Let's see what the evidence says. Whenever we take this particular call, we need to see about the woman's age, the duration of infertility, pelvic pain, other causes of infertility, what is her preference, and what are the previous treatments she has received. If you look at the ASRM guideline of 2012, it says that because it is very uncommon to find an advanced endometriosis in a patient who's asymptomatic and with a normal ultrasound, there is extremely low utility in performing laparoscopy in asymptomatic or those with mild symptoms. It has further made these recommendations. The benefit of laparoscopic treatment for minimal or mild endometriosis is insufficient to recommend laparoscopy solely to increase the likelihood of pregnancy. And since we really do not know what is the impact of this endometriosis on the fertility, we should not be exposing our patient to the surgical risks. Hence, laparoscopy of asymptomatic women with infertility simply to rule out or confirm disease is absolutely unwarranted. Even the ESHRE in the latest guidelines of 2022 has further reiterated that clinicians are not recommended to routinely perform surgery prior to ART to improve the live birth rates in stage 1 and 2 endometriosis, as the potential benefits are unclear. Despite our advice and despite showing her all the evidence, this patient insisted on laparoscopy. The question that we need to now say that what consent should we take? What should we plan for her? Should it be diagnostic or should it be an operative laparoscopy? So if you look at the evidence, the Cochrane review of 2020 clearly says that operative laparoscopy is far more effective than diagnostic laparoscopy in improving the ongoing pregnancy rates. And in case we are doing a laparoscopy and we find endometriosis, we should do a complete surgical removal, which includes excision, ablation, as well as ediosolysis, because it is only then it has a positive effect in regards to live birth rate and ongoing pregnancy rates. The ESHRE guidelines of 2014 suggested that maybe carbon dioxide laser vaporization has a higher cumulative spontaneous pregnancy rates as compared to monopolar electrocoagulation. And all this should be discussed with the patient and a shared decision taken before we go ahead with a laparoscopy. The Cochrane of 2020 has further added, there's a moderate quality evidence that whenever we are doing laparoscopy for a minimal or mild endometriosis and we do an operative laparoscopy, it improves the viable intrauterine pregnancy rate when compared to a diagnostic laparoscopy alone. So one thing definitely is conclusive from this particular thing is that in case we are doing a laparoscopy, it should not be diagnostic, it definitely should be operative laparoscopy. Now we have done a laparoscopy and we find that it's stage 1 and 2 and we have done the necessary surgery. The next question that we need to ask is, what do I do after this? How do I help her to get pregnant? There's no consensus as to the optimal approach. Factors which help us to make a decision is patient's age, patient's preference, procedure risks, the cost, maybe the insurance coverage in some of the countries, but female age is the most important factor. And the options available to us is expectant management, superovulation with IUI, or we have IVF. Now, what happens in those cases where we suspect that she has stage 1 and 2 and we have not done a laparoscopy? How are we going to help these patients become pregnant? The 2 randomized controlled trials have supported the view that COH, that's controlled ovarian hyperstimulation with IUI, is better than no treatment for endometriosis. Human and cold workers have found that the cumulative live birth rate was 5-fold higher following controlled ovarian hyperstimulation and IUI. Putting all this evidence in one area, in the crossover RCTs among patients with unexplained infertility or surgically corrected endometriosis, the pregnancy rate per cycle was significantly higher with 4 cycles of CC and IUI as compared to 4 cycles of timed intercourse. In yet another RCT of 49 women in stage 1 and 2 endometriosis, where they gave 3 cycles of gonadotrophins and IUI and compared it with 6 months of expectant management, the pregnancy rate in the gonadotrophin was 15% as compared to 4% in the untreated group. Thus, they suggested that maybe SO, that is superovulation with IUI, may be a viable treatment option in the patients with stage 1 or 2 endometriosis as an alternate to an IVF or further surgical therapy. As far as knowing whether this particular method of that's controlled ovarian hyperstimulation and IUI is going to be more successful after expectant management where we have not done laparoscopy or where we have done laparoscopy, still the verdict is not out as the evidence is still insufficient. So putting all of it more in a practical approach, if your patient is less than 35 years of age, in a stage 1 and 2 endometriosis, who desire a trial of natural conception, we can give them 6 months of timed intercourse. If they do not conceive, then 3 cycles of ovulation induction with IUI. If they still do not conceive, we need to move on for IVF. In those who are more than 35 years of age, since age is the most important factor, we have to be more aggressive. Motivate them, encourage them to undergo superovulation with IUI, or we need to consider an IVF. And to put it all together in the ASHRAE, that's 2022 guidelines, they say that in these particular patients of stage 1 and 2 endometriosis, clinicians may perform IUI with ovarian stimulation instead of expectant management as it increases pregnancy rates. And clinicians may consider performing IUI with ovarian stimulation within 6 months after surgical treatment. All the studies that they have looked at are the ones where gonadotrophins have been used. For anti-estrogen therapy, there are not enough studies as far as its use in the case of endometriosis is concerned. Coming now to the second case. She's a 28-year-old lady, married for 2 years. Very sensible. She came to us for a preconception counseling. They have not as yet started to conceive, but she just wants to see that everything is fine. She has regular menstrual cycles, absolutely asymptomatic. We did an ultrasound and unfortunately we found a 4-centimeter endometrioma in the right ovary. Male factor is perfectly normal. The dilemma to us gynecologists is, what do I tell her? Should she go in for a fertility treatment since she has an endometrioma or not? So if you look at the evidence, which was a paper published in BOG 2017, they say that if it is a young woman with regular menstrual cycles and an incidental finding of ovarian endometrioma without any suspicion of malignancy who wish to conceive, they should be encouraged to try natural conception before seeking fertility treatment. They have not specified the time duration, but they said that they definitely can be given a trial of natural conception. But those women who are of elderly age or the ones who have a reduced ovarian reserve, conservative management may not be the right line of treatment for them, and one should look for using much higher fertility treatment management. Now, this is the other case which I think Dr. Nymphia had dealt with it very clearly, but since her voice was a little there, so maybe I'll just put on the highlights for this. This is the same case, 4-centimeter endometrioma, but when they investigated, they found that the male factor infertility was there, and she was thus counseled to undergo an IVF and ICSI. The question that we need to say, she has a 4-centimeter endometrioma, should I do a surgery prior to ART? The evidence says that there's no evidence that cystectomy prior to treatment with ART improves pregnancy rate. And it is extremely important that we need to counsel the particular patient that ovarian surgery will reduce the number of oocytes retrieved. It reduces the peak estradiol levels and increases the FSH level. In 13% of cases, it's known to cause ovarian failure. And the resection of endometrioma larger than 3 centimeter does not seem to improve the pregnancy rates. If we are leaving behind the endometrioma, our patients have a lot of fears. How can we allay the fears of leaving behind an endometrioma? By telling them that endometrioma itself does not alter the ovarian function. There's no evidence that the cysts, if they're left and she becomes pregnant, it's going to adversely affect her pregnancy or live birth rates. There's no reduced responsiveness of the ovary to COH in women who have endometrioma, and there's no risk of growth or rupture of the endometriomas with ovarian stimulation. While doing an IVF and pick up with an endometrioma, antibiotic prophylaxis is recommended. The second fear that we need to allay that many patients do have, that if I leave behind an endometrioma, what is my risk for developing malignancy? So the risk of missing an occult malignancy is extremely low. The lifetime probability of having a malignancy is about 1 to 2%. Yes, we need to tell the particular patient about this, but this does not mean that we cannot delay the surgery if you're looking for a pregnancy, and it can be done after the patient becomes pregnant and delivers. So if you look at the ASM guidelines in 2012 and then ESHRE in 2022, both have clearly stated that clinicians are not recommended to routinely perform surgery for ovarian endometrioma prior to ART to improve live birth rates, as the current evidence shows no benefit and surgery is likely to have a negative impact on the ovarian reserve. So which are the conditions when we can consider surgery prior to ART? It's only if the patient has severe endometriosis associated pain, if we feel we'll not be able to access the follicles, if there's a suspicion of malignancy. When do we proceed directly to ART? We do not even think about the surgery. She's asymptomatic, the age is advanced, she has reduced ovarian reserve, bilateral endometriomas, or if she's had a previous ovarian surgery. So coming to the third case, she's a 32-year-old woman trying for natural conception for last 1 year, severe dysmenorrhea. She has already been previously diagnosed to have severe endometriosis, but she's never been operated. Luckily, she's never been touched prior to this. We evaluated her for infertility. We found the image was not too bad. It was 2 and the AFC was 10. And on the transvaginal ultrasound, the uterus was retroverted, bulky, with adenomyosis, restricted mobility. Both the ovaries were lying in the pouch of Douglas with restricted mobility, kissing, but there was no endometrioma. We know that she's a case of moderate and severe endometriosis at stage 3 and 4. The question is, should we give her infertility treatment or not? We need to understand that there's no role of expectant management in such a case. In the absence of any other cause of infertility, we have 2 options, IVF, or we can consider conservative surgery because she has come to us with severe dysmenorrhea. IVF is a better therapeutic option if a woman has had another 1 or 2 infertility operations in the past, she has failed to conceive after conservative surgery, or she has got a male tubal or a poor ovarian reserve or an advanced maternal age. Surgery for a deep endometriosis before ART. Surgical treatment before ART is associated with low live birth rate, clinical pregnancy rate, and a mean number of oocytes retrieved. Surgical treatment for severe endometriosis is associated with significant surgical morbidity, and hence there's insufficient evidence to recommend surgery routinely before ART. Surgical intervention is to be contemplated only after careful consideration and appropriate counseling as well as discussion, and it is predominantly for a pain relief and not to improve the outcomes of the pregnancy. So ESHRE 2022 clearly says the decision to offer surgical excision of a deep endometriosis prior to ART should be guided by the pain symptoms and the patient's preference, as its effectiveness on reproductive outcome is uncertain due to lack of randomized studies. Whenever we talk of a principal or the primary surgery in a symptomatic woman with infertility, as Dr. Demphier also stated, it has to be done by the person who's expert at doing it, because patient has a chance only once for going through a surgery. It should be extensive, it should be complete, which includes excision, ablation, endometriosis, and complete surgical removal of endometriosis. And the main aim is to stage and treat the endometriosis, improve the fertility, as well as to reduce the pain. In the latest guidelines of ESHRE, they have talked about the endometriosis fertility index. That is at the end of a primary surgery. By calculating the endometriosis fertility index, we can estimate as to what ART method is this particular patient going to benefit to have a pregnancy in future. It is validated, it's reproducible, and it is extremely cost effective. And this is the endometriosis infertility index. So on the left side, this particular index is calculated from a score from 0 to 10, of which 5 are contributed by the historical factors, which includes the age, the duration of infertility, and the previous pregnancy, and the other 5 by the surgical factors, which includes the least function score, which is found or calculated at the end of the surgery, the AFS endometriosis score, and the AFS score. 5 and 5, that's equal weightage is given, and if the score is more than 6, then the chances of the patient conceiving in future after the surgery is good. And this you can see by the right side graph. Now this is for this particular calculation of the pregnancy rate is for the non-IVF conceptions. So if the score is less than 5, this particular patient may not be able to conceive herself and will require some of the other ART support. If it is 7 to 8, 8 to 10, the chances of her conceiving naturally or with minimal support is considered to be good. This is a new concept or the factor which has been added into the ESHRE 2022 guidelines. So these particular guidelines further go on to say that what are the ART options after primary surgery? So if the tubal patency is uncertain, the use of IUI with ovarian stimulation could be considered if the patient is extremely insistent. This is a new factor where they've said that yes, there is a possibility of doing IUI if that is the patient's preference. ART should be performed whenever, along with endometriosis, you've got tubal function, male factor, or you have a low EFI score. Another new factor in the ESHRE guidelines is they say that both GnRH antagonist as well as agonist protocols can be offered based on patients' and physicians' preferences, as no difference in pregnancy or live birth rates have been determined. And the patient should be told that by using the ART methods, the recurrence rate of endometriosis is not increased. As far as using the hormonal treatment, which we all were using previously for endometriosis, that is a long protocol of GnRH agonist, the latest guidelines clearly states that the extended administration of GnRH agonist prior to ART treatment to improve live birth rate in infertile women with endometriosis is not recommended, as benefit is uncertain. Similarly, for prolonged administration of COC or progesterones as a pre-treatment, they have said there's insufficient evidence to recommend that too. Coming to the fourth and the last case, that's this particular patient. She went in for an IVF, unfortunately failed. She took a very long time to reconcile, and after 1 year, she further again decided to go in for the next IVF cycle. She did not have any frozen embryos. When we did an ultrasound, because she has come back again with severe pain, we found that they were again endometriomas of varying size. The AMH previously, which was 2, now the AMH was found to be 1. The question that I need to ask myself, should I expose her to a repeat surgery since she has endometriomas and severe pains? We need to understand that the repeat surgery does not improve fertility. The indications of repeat surgery is very stringent. Severe recurrent pain that impairs the quality of life, or a treatment of a symptomatic endometrioma. So if we look at the recommendation, it clearly states that the major benefit of any surgery takes place after the first procedure. If initial surgery does not result in pregnancy, subsequent surgical procedures are not likely to be effective for increasing fecundity. Thus, the clinicians must balance the limited benefits of second or third operative surgery as compared to the risks which are involved with the repeat surgery, since this surgery does not increase the likelihood of a birth rate. They have clearly stated women who have failed to conceive after primary surgical resection of endometriosis should proceed directly with the ART treatment and should not think about a second or a third surgery. Thus, coming to a conclusion, medical treatment for endometriosis does not improve the spontaneous pregnancy rate. There is some evidence in the latest ESHRE guidelines which says that operative surgery may be beneficial in mild and minimal and mild endometriosis as compared to diagnostic. There's a controversial evidence regarding removal of endometriomas owing to potential impact on the ovarian reserve. Further RCTs are required to assess the potential benefits of aggressive surgery and reoperative procedures. ART improves pregnancy rates as compared to no treatment, but the pregnancy rates remain lower than that of endometriosis-free women. And if you look at this particular chart, IVF definitely does improve the rate, but as compared to those who do not have endometriosis, in stage 3 and 4, there's a 21% reduction in the pregnancy implantation rate and 21% reduction in clinical pregnancy rate. But in case of stage 1 and 2 endometriosis, there's no difference in the implantation and the clinical pregnancy rate. And I would like to end with this particular last slide, and this is about the ESHRE guidelines, which had come in 2014, and the repeat guidelines, which have come latest, that's 2022. What is different from the guideline of 2014? So if you look at the treatment of endometriosis-associated infertility, they have said that the extended administration of GnRH agonist prior to ART treatment to improve the live birth rates is no longer recommended due to unclear benefits. And they have added the endometriosis fertility index so as to be able to define which patients after the surgical procedure, what options they will require to achieve better pregnancy rate. So with this, I would like to end and say my sincere thanks to each one of us. We know that the road of treating endometriosis is extremely long, but all of us have to have hope in our hearts, and that is how we will go on. Thank you so much.
Thank you, Dr. Jyoti. That your talk was just brilliant. The case-wise discussion was much more easy to, and that made it much more easy to understand the things. Now I invite Brigadier Sharma sir.
Thank you, actually, Dr. Valecha and Dr. Jyoti, they showed up all the aspects of endometriosis and infertility. When we talk about, when we are suspecting malignancy in endometriosis, so I would like to ask Dr. Jyoti Bhaskar, when does she, suspect that this patient of endometriosis may be having malignancy? What are the criteria which she will take?
Sir,
should know this.
Sir, in this particular, it will be more based on the symptoms of the patient as well as the ultrasound findings. So we need to base it predominantly on the ultrasound findings, which will show markedly increased vascularity. There may be certain areas which are solid areas, and there may be certain excrescences which may be coming around, or there's a sudden enlargement of the endometrioma that to see over there. As far as the CA-125 concerned, there's not much of a role, is it? But if it comes in thousands and 2000s, which was less previously, that could give us a rare idea. But although it is not considered to be a great criteria for diagnosis.
Very well said, ma'am. Like if you do the ultrasonography of an endometrioma, single endometrioma, you will always find the wall is double layered, hyperechoic, hypoechoic, and hyperechoic. And if you put color into that, the hypoechoic area will all have blood vessels in that. So if you find this, the sandwich pattern of the wall is getting distorted, that may be initial stages of malignancy. So that, as you mentioned, so initially you can detect or start suspecting that this lady may be having, because that 3-layer wall is absent there. And especially it becomes more difficult when there's a TO mass along with endometriosis. So differentiate, so there one has to be very careful. And the patient has to be told in case we are postponing surgery that though incidence is very less, there's a possibility because it is a medical legal world today. So we should give it in writing to them for that part. Dr. Velecha, it was very nice presentation. In your case, the HSC showed corneal block. While, normally endometriosis would be associated with the femoral block because of adhesions. So most of the time the tubes are open, but if they block, they are blocked, in the femoral end. Now, would you consider tuberculosis associated in such a case where there is a corneal block with endometrioma or endometriosis?
Yes, in any case, we generally, whenever there is a doubt, we evaluate. Whenever we take a patient up for an IVF, we rule out a cost-generative perspective. So that is in our routine protocol.
So I just want to bring it to the notice of the audience. There is an increased incidence of genetic tuberculosis in the patients of endometriosis. So in case, even if you don't find anything, obviously, you should investigate them for tuberculosis, even if there's no corneal block. But if there's a corneal block, definitely they should be, treated for that. And whenever we are, like sometimes, like when doing home pickup, some amount of endometriotic fluid also comes out. So that should be sent for cytology as a routine. But don't just throw it, because that may also help us in, finding out if there's a malignancy or not. At least we have recorded that some cytology has been done and it did not show that time. So aspiration of endometrioma during ovum pickup should be done or not, that would also remain controversial. Because now the patient, you have picked up all the follicles and endometrioma is just, easy pluckable in front of you. So it will tempt you to put a needle into that. So that will remain debate. Some people will agree, some people will not agree because of possibility of, pelvic abscess formation later on. So that I will leave it to that. And now, when Madam Jyoti had said that, the long protocol should not be given to these patients, it does not benefit. But it has got a role in some subset of patients, where they have a, severe pelvic pain and you don't want to operate and she has to be taken for IVF. So in that particular case, one may give long protocols, reduce the pain and then do the stimulation. Otherwise, during the whole process of IVF, she'll have so much of pain that she will, possibly will be having more morbidity because of the pain. In that subgroup of patients, where the pelvic pain is more, we can give long protocol and once the pain is reduced and then do the stimulation. And then the stimulation should be done with HMG rather than, recombinant episode.
Just in case the patient is delaying her treatment for some other reason, and then should we be giving this long protocol in those patients, though they are not having that much pain, but we have planned IVF and patient is delaying due to some reason. So will it be beneficial 10%, 20%? Not at all beneficial.
No, I think at least if it will not help, but at least not allow the endometrioma to grow further.
Okay.
So some reason she is postponing, she has got some social reasons and all. So in that particular group of patients also possibly we can give them long protocol.
Now I invite Dr. Sharda Jain ma'am. Thanks, sir.
Thank you very much.
I think as far as endometriosis and myself are concerned, my fundamentals are rather clear. I feel, there is no role of a diagnostic laparoscopy, and I very strongly feel there is no role of, if we find on a transvaginal sonography, there are no masses, only patient has got a problem of dysmenorrhea, sometimes dyspareunia, and there is still not masses, then I think, there is no place for surgical line of treatment. And I feel, once a patient has come to you and she wants to have a child, then I do not believe in timed intercourse and follicle monitoring. That gives a pregnancy rate of very little, but if it is combined with the control ovarian hyperstimulation plus IUI, you can find the literature says 5 to 6 times the pregnancy rate is there. Now, if this particular patient complains of a pain, then the pain is the priority and not the infertility. So I think, we must discuss it out with her. What does she want? And I find in case if they are not big masses, people still believe that, if you give GnRH analog injection to them, one injection takes away 50% of pain. So I'm still, though in 2022, ASHRAM guideline says that analog have no place in stage 3 and 4. हमें अंग्रेजों को बहुत ज्यादा सीरियसली नहीं लेना चाहिए. I very strongly feel आपका जो चल रहा है ढल रहा है उसको आप देखो कैसा है. I feel that stage 3 and 4 disease, definitely this lady is infertile for 4 years, 5 years, 6 years, and if she has a significant amount of pain, she already has a as Dr. Brigadier Sharma has said, it's my policy, and I think people who work with me know that I definitely rule out tuberculosis in such patients. And in my practice, the incidence of tuberculosis and endometriosis 50%. And this Cornwall block definitely is a signal that probably may be having tuberculosis per se, which is the cause of the block. I feel in a stage 3 and 4 disease already things are compromised. You definitely find that the follicles are few in such patients. AOMH by default is less in such patients. In case if you offer a surgery, you do tell her that no medical treatment is required after surgery. She should straight away go for an IVF. And I find that the results are great. The results are great. हम हर बार अंग्रेजों की बात सुने ये जरूरी नहीं है. What results you find with yourself, I find fragmented IVF has done a lot of wonders in endometriosis, and I feel that in my own practice, once the eggs are retrieved and in case with a low AMH, I definitely give them an analog, and I find that the results are much better.
Ma'am, for audience sake, what is your message? Frequently, you will see that patients are given treatment like COH and IUI, where you even suspect mild or minimal endometriosis. There is some pain, though you are not seeing any endometrioma. In those particular patients, should we first see the state of tubes before doing IUI or not?
Doctor, मैं तो एक बात बिल्कुल clear है. If I am touching a patient of IUI, 3 things are clear. Husband should be okay. She should be ovulating, and she must have a 1 patent tube before you touch her. I think the gynecologists in India who are not trained in infertility are the ones who do not get semen examination done, who do not get tube testing. They go ahead with an IUI. That everybody who's listening may should definitely know that all these parameters must be seen. Semen analysis, whether she's ovulating or not, what is the tubal status for us, and the 4th is for tuberculosis, as far as I'm concerned.
Thank you, ma'am. I wanted to give this message to the audience. Thank you. Now I invite Dr. Jyoti Bali.
I think both the speakers, I must compliment, they covered endometriosis beautifully and have set the mind thinking again as to do we bring in any change with the new times. I think what Dr. Sharda Jain ma'am said, I quite agree with that. But laparoscopy, sometimes if done for another reason, additions can be cleared and the patient can be pain-free. If she's complaining of, if pain is a primary complaint, then it does help if those additions are released and there may not be any masses in the ovary or endometrioma visible on the ultrasound. But if she's that symptomatic, I think laparoscopy surgery does relieve pain if we are doing it for some other factor, or maybe there was another indication for it. Maybe she had hydrosalpingo seen on the scan. It was done for clipping, but at the same time there were discoveries of additions. We've had many patients coming to us for that, and laparoscopy in that scenario, I think, ma'am, you would agree with me, Dr. Sharda Jain, ma'am, that it does help. But yes, the time period from a surgery to conceiving should be categorically explained that she doesn't have time for 6 months to wait because it is a recurring disease. So only thing that will help her is getting the uterus pregnant as soon as possible. And we all know IUI offers 10 to 15% per cycle, whereas IVF offers 50 to 60% per attempt. So we have to balance those two decisions where as to what should be the chart, and time has to be taken into consideration. She cannot keep on trying IUI. After all, 10-15% is the result worldwide. So I think the chart should be made by the clinician and the patient in an agreement as to when she will move on from IUI and grade 1 and grade 2. 3 and 4, of course, it is straight away IVF. Protocol-wise, antagonist, and versus long protocol, there is a marginal difference in the Cochrane review. You can even use antagonist, which is much more comfortable rather than using a long protocol, because earlier we were all using long protocol. In the studies, there is a marginal difference in the two results, but antagonist is good enough for even patients with endometriosis.
Thank you, Dr. Jyoti. Now I invite Dr. Shivani Sachdev.
Thank you very much, Poonam ma'am, Dr. Nymphia and Dr. Jyoti. It was really wonderful presentation, and Dr. Jyoti especially because the new guidelines have come out now after 10 years almost by ASHRAE for endometriosis. So it was very good for us to get an update just for fertility now. Instead of ASRM, the more reliance is being paid for EFI, the endometriosis fertility index guidelines as compared to the ASRM, because that is more prognostic towards the pregnancy rate. And in the new guidelines, the role of letrozole has come for pain relief of endometriosis. So you can give like long-term daily letrozole for pain relief. That was only just the two things. You have covered everything. I mean, it was really wonderful. Thank you.
Thank you, Dr. Shivani. How much time you need to give letrozole and how much doses for audience sake? Please elaborate that.
Ma'am, the recommendation, they were just saying that for pain relief, you can use letrozole in combination with oral contraceptive pill with agonist or antagonist, whatever, not really specified. But when I am using, what I have read is 2.5 milligram once a day for 30 days. Actually, we are using for IVF also. If the person has failed IVF, in the last conference, abhi hua tha KMOX, we were discussing in the conference with some other people from Mumbai also, ki if nowadays we know that most of the time when IVF fails, you have to work on the uterine factor. So actually they are doing 3 months of lupride depot and each month 2.5 letrozole once a day for 25 or 30 days. Then the period comes, then the next month again depot plus letrozole. So 3 months of this and then after that embryo transfer.
Add back therapy if we are giving 3 doses of lupride.
So Yes, ASHRAE guidelines, which Dr. Shivani has just quoted. So there are some studies in that where they have used the letrozole, but they've used it either in combination with OCP or they have used it with progesterone. And the dose they have recommended is 5 months, and they've given up to 3 months for that particular one. But there's still studies, and that's why it doesn't come in any guideline, but they have got some benefit out of giving that.
Thank you. Now I invite Dr. Dinesh Kansal to elaborate on the surgical aspect of the disease.
The tussle begins now.
Thank you, Dr. Poonam, for inviting me. Thank you, Dr. Shardaji. And very rightly, Dr. Poonam said I should not be speaking on IVF, it should be more on laparoscopic surgery.
Yes.
So basically, there are two complaints of the patient. Either it is pain or it is infertility. And if it's a severe pain, not early pain which subsides with NSAIDs, if it is severe pain, severe dyspareunia or infertility, which is not responding to our controlled ovarian hyperstimulation, then we have to go for surgery. And earlier we used to say if the patient has pain symptoms, then only we do the excision of deep endometriosis. But now it seems that even for infertility patients, if you can excise as much of deep endometriosis if possible. So what we do is near the insertion of uterosacral, where you see the lesions, you try to excise an amount so that recurrence rates are less, and as well as the patient has decreased pain, she has chances of spontaneous conception. And also the secondary surgeries are very difficult in endometriosis, so we like to do maximum in the very first surgery. And it is definitely giving better pregnancy rates also, because the chemical environment improves, the prostaglandins and cytokines and other factors. So there's little change in the infertility surgical treatment that we are now doing. And the next is if they are very large endometriomas. Sometimes we have endometriomas coming up to the ribs, up to the umbilicus. So in these cases, we don't excise or do the cystectomy completely at first go. What we should do is we should aspirate in the first sitting. We should counsel the patient for her to have the best ovarian reserve, it's better to do in 2 sittings. So first sitting we aspirate the ovarian cyst, and the next sitting we do the peeling of the cyst. I think that's the latest consult.
I would like to know from you how early you have seen the recurrence of endometrioma. I mean, you have sent the patient after doing the surgery, and within how much time she is coming back to you with another endometrioma?
Yeah. It basically depends upon 2 factors. One is how progressive the disease is in that particular patient. Second is how much I was able to excise, how much disease I was able to excise. Like, if we have repeat surgeries for a patient and we want to do conservative management, it's not possible to excise the disease completely. And these are the cases who come back very early with almost, quite a bit of masses on both the sides. And it can happen even 6 months, 1 year. Because initially,
I will share my experience. The earliest, those patients who are an operated patient is shown the clear field. It has come back as early as 6 weeks, and we have also seen, you operate such patients, and when you're waiting for an IVF, they have conceived on their own in 2 months' time. So yeah, I think I agree with her that the chemical atmosphere changes drastically in such patients, and they definitely have the golden period. I always call is a 6 months time. I have seen as early as 6 weeks after a complete surgery.
Yeah, ma'am perfectly pointed out golden period. Like, we have in myocardial infarct golden hour. For CVS, we have golden hour. Similarly, we have golden period post-surgery for endometriosis. Very true, ma'am.
Thank you, Dr. Dinesh. And
good afternoon.
my doctor.
Dr. Poonam, I wanted to ask Dr. Dinesh a question. Ma'am, you're talking about 2 surgeries required in such patients where you do aspiration and then you require a second surgery. So won't you recommend a ovum pickup in between and freeze the embryos and then go for second surgery?
Yeah, the very large cyst, that's the recommendation, because we had patients who had, because the cyst wall is so thin, if you try to peel it off, you are not able to do it, and almost whole of the ovary comes out. So usually the patient responds in about 3 months' time. You put the patient on medical treatment after aspiration, and when you see they become about 5-6 centimeters, then you go ahead and do the cystectomy.
Dr. Dinesh, I'm hearing this for the first time. If it's a good surgeon operating, this kind of thing should not happen.
Ma'am, if the wall is so thin,
hearing for the first time that you take the surgery, you aspirate once and 3 months later you do it again.
Ma'am, this has come for past 2 years only, that this is how we should go for very large, extremely large masses. But if the total thickness is less than 1 millimeter, where is the place to take out the cyst and keep the ovary? It's absolutely stuck together and not possible to do.
Dr. Jyoti, you want to say something? Dr. Archana? Dr. Jyoti? Unmute yourself.
Yes. First of all, a very good afternoon. Both the speakers have done a very brilliant job, and I feel the broth of endometriosis has been well simplified and cooked, and too many experts, I may only confuse more. So it's better that what we have learned is diagnostic laparoscopy ka role nahi hai. There is no role of medical treatment either pre or post, and instead of wasting time, we should refer the patient as early to an ART center, either for IUI or IVF ICSI, depending upon the case. And always, whenever we do a laparoscopy, we should always send the tissue for malignancy, as we were discussing earlier, however young the patient may be and whatever the remotest possibility of malignancy. And always do an AMH also prior to and post surgery, just to help her counsel, this is your ovarian reserve. And Dr. Poonam was asking how early we did the patient had a laparoscopy in the previous month, and the following month she again refilled it. So it can be as early as in the first cycle itself.
Dr. Jyoti, I had also seen, that is why I asked this question.
Yes.
I had also seen the patient had surgery.
She had
and very large endometrioma
Very large.
developed immediately in the next cycle.
immediately in the
Yes.
next cycle. Yes.
That
I
is
think
why I asked.
And
possibly some bleeders were left that time in the first surgery.
Okay.
Possibly some bleeder must have been left in that surgery. That is why it filled up so fast.
No, sir. We have,
the bleeders होंगे तब तो वो और जल्दी acutely present करेंगे.
exactly. This is after the next period.
Yeah, next period while we are stimulating her for IVF. This was seen.
Human response is so variable that one cannot say anything.
Yes.
Dr. Archana,
And at the same time, there has been a patient of mine who had a beautiful laparoscopy done, and she has had 2 children, no recurrence, no pain, nothing. Every time she comes with pain, I feel that maybe she has got a recurrence, but maybe simply adhesions, but no recurrence at all. A beautiful work done.
Thank you, Dr. Jyoti. Now I invite Dr. Megha.
Thank you, ma'am. Good afternoon. I would like to ask a question to Dr. Dinesh, ma'am, if she's there. That after surgery and removing the cyst, should we go for suturing of the ovaries? Because I heard a recent lecture, I heard somewhere a laparoscopic surgeon saying that you should suture the ovary so that raw area is not exposed and for the better outcome of the result of the surgery for endometriosis. Ma'am, your call.
Yeah, Dr. Megha, I think some surgeons are doing it completely, suturing it in such a way so that raw area is not exposed outside, and they say that adhesions would be less. But then this is very risky, as Dr. Sharma said. Suppose there is a bleeder left inside. There's always some oozing. If it happens to form a hematoma and gets infected, that would be very tragic for the patient. You will have to do self-ingo oophorectomy for that patient, and she will suture it completely. If after cystectomy we feel the look of the ovary is very irregular, part of it is here, part of it is here, so then we take just one simple suture to approximate the edges, and that's it, not more than that.
Thank you.
Thank you.
Madam, can I ask one question to Dr. Kansal?
Yeah.
Madam, this just a thought in my mind, not a question as such. Like if you are aspirating the big, thin-walled endometrioma and you're leaving the walls, can we put some chemical inside, like earlier, tetracycline was put, so that there is a chemical cicatrization? So, the whole cyst walls will, collapse and they'll get adhesion, and then we can go ahead with the IVF. And we need not do second surgery for that, because there will be no refilling. The tetracycline, earlier, if you remember, we used to put it in the cyst walls and all, or in the fistulas also to block the, the chemical burning inside, so that, the walls would collapse and they will not, fill up again.
The chemical sclerosis is one of the treatments which is known, but is not routinely being practiced. Alcohol is inserted, is pushed inside the cyst. You wait for some time and then wash it off. Also, you can also do CO2 laser, just superficial coagulation, or with bipolar for large cyst. But like putting in a catheter, and you said leaving it there.
Sorry. Yeah, the tetracycline, when you put it inside, you don't have to aspirate it also. And this, will cause a chemical cicatrization.
You leave it there. Okay, so this is a very novel idea. I never heard of it, but maybe somebody
can try that.
Yeah.
Because then we don't have to do second surgery to peel off. The whole cyst wall will be collapsed.
It will collapse.
We can go ahead with IVF.
Very new idea, absolutely.
Archana, you wish to comment?
Yes, ma'am. I just wish to share a case. This was not an infertility patient I did an endometriotic surgery for. She had huge endometrioma, around 7-8 centimeter, I remember. And I operated upon her with the surgeon, and we operated quite a decent job. But there was a lot of evidence suggesting that she's probably tubercular also. So we gave her ATT, and in fact, she presented 3 months within the surgery, and she was having, left-sided hydroureteronephrosis. So we had to immediately operate upon her in 2-3 days' time and relieve that pain. And once we saw the abdomen after giving ATT, things were so much better. We could do such a nice surgery for her. I mean, I just wanted to highlight the importance of tuberculosis, not to be, ruled out, to be overlooked.
That means we should not get excited after making the diagnosis of endometriosis. Ke diagnosis ban gaya. We need to rule out tuberculosis also in these patients. Specifically, you see things like corneal block and adhesions and pain and weight loss.
And suppose if the patient is not rupturing after the injection, in case she's for IUI, then also we should always think of endometriosis and PCOD, both the things. That's a different topic altogether now.
Sir, what is
inflammation is the process. Inflammation is a process. You'll find definitely this is the cause for both the things, and that is why the adhesions are there. I think adhesion is one of the very significant features that in advanced cases there is an infertility.
And I think the worst cases are where you have adenomyosis as well as severe endometriosis.
Yes.
Adenomyosis is worst.
Now I invite Dr. Aruna Saxena. You want to say something?
Hi, Dr. Poonam. The topics are covered so meticulously by both the speakers, and all the experts have already commented. I just wanted to make a point. When anyone come for fertility to primary gynecologist, rather than the age, they should look at the ovarian reserve. Just do a simple ultrasound and look for the antral follicle count, because we see a lot of cases of poor ovarian reserve in young patients. So, in my opinion, endometriosis with age should not be the criteria. It should be ovarian reserve. And if the patient is young, we should alert them to plan for early pregnancy. And even we do see a lot of elderly women coming to us who just come for a normal checkup. Doctor, I want to check my fertility. I'm going abroad, I'm working. And if we find even mild endometriosis, grade 1 or grade 2, even little cyst, we should alert them. We should not delay pregnancy. So that was the point I wanted to make.
Dr. Aruna,
I think you were on the topic of ovarian reserve. I would just wish to tell that as such, I find Indian ladies' ovarian reserve definitely gets compromised only 4, 5 years or 6 years earlier than the Western counterpart.
Yes,
and this particular part is more so in tuberculosis and endometriosis. Sometimes, it is idiopathic also. But I think it's a malnutrition factor or what it is. Ovarian reserve is really compromised.
And when do you go for ovum preservation? Because endometriosis patients often ask us, Madam, if I have severe endometriosis, should I go for ovum preservation? And how fruitful it is? What is IVF experts' opinion? I would like to know.
Ma'am, ovum preservation is common these days, but honestly, I am doing embryo preservation for such women. If they want fertility and if they have a fixed partner, we'll suggest them to go for embryo freezing, and they can do transfer at the time of their convenience after finishing the carrier and everything when they are over with it. So this is what I'm doing.
I just want your honest opinion about this. Egg donation. Sir.
I'm sorry I didn't get you, ma'am.
Doctor, egg donation, what is your final comment about it? How fruitful is, how we should advise them, and what is the pregnancy rate you've seen after egg preservation?
No, the thing is, in endometriosis,
not endometriosis as such. Sir, as such.
Of the egg donation.
Ovum preservation, sir.
Ovum preservation. Oocyte freezing, vitrification of oocytes.
To get a good blastocyst, you require at least 10 oocytes. So it is not very cost effective. I would say we should not give too much of hope to the patient that, okay, we are doing your social freezing and all, but we should tell them the beginning only. That especially if they have had such a poor ovarian reserve, freezing their oocytes, depending on the age also, the number of, there is some study where they mentioned at that particular age you require that many oocytes to make, one blastocyst if you have frozen them. So it is not a very, very, I would say, productive way of preserving the thing. In case they get married and have an embryo preservation, that is much better.
Yes, embryo preservation is at any day much better than oocyte preservation. But if we don't have any,
you must be freezing. What is your take on that? How many oocyte
preservation? Yeah, almost on daily basis we are freezing oocyte, daily basis, and we are getting excellent survival rate because our embryologists went to Japan for training just for oocyte preservation. and the Kitazato medium is working very well, and the survival rate is close to 100%. But as you rightly pointed out, blastocyst, the competence of the blastocyst may not be the same because of the ill effects of endometriosis or ill effects of the freezing. And for social freezing, worldwide studies are published that most of the people who are frozen have rarely anybody has used, very few people actually use.
That is the problem. That is the problem.
डॉक्टर साहब this is what I feel कि अगर आपको 30 साल तक नहीं मिला पार्टनर तो फिर बाद में भी your mentality पार्टनर मिलने वाला नहीं है.
It's better to have a donor sperm than make an embryo freeze it.
I think I will love Dr. Jyoti Bhaskar this ashram guidelines of 22 to study कि ये जो इंजेक्शन GNR ने चैनलों की छुट्टी कर दी है उसके बारे में मैं पढ़ना चाहती हूँ.
हाँ जी मैम, I'll send it across. Ma'am, it's only for infertility, not for pain. For pain treatment.
For pain
तो बहुत ही बढ़िया चीज है डॉक्टर साहब. आप पेन का एक इंजेक्शन लगाओ, 50% pain goes away in 15 days, and you give another shot, and you find that the pain disappears, provided it is not a very big one.
So, ma'am, their comment is only for infertility, where you're using long protocols. They say there's no need for that. जैसे आपने बोला कि surgery के बाद you should go straight away for the methods for helping them to conceive. That's what they have commented.
So there is a question in the chat box: how to go for TB testing in endometrioma? What test? So I think this is same gene expert test which we are doing on endometrium.
मैडम जीन एक्सपर्ट में तो कुछ भी पॉजिटिव नहीं है. Not a single patient is positive.
So ma'am, what should we
हम लोग तो TB PCR कराते.
Okay, TB PCR on endometrial tissue.
Yes, endometrial tissue. And this latrose brings down the estrogen levels, and that's why the elimination of pain is there.
So we had invited Dr. Sunita Arora also, but I can't see her. Dr. Sunita, if you are there, please.
Sunita Arora.
I don't think she is there. I didn't see her. Maybe she.
Madam, Yukti is here. Yukti is here. She's also again another infertility expert if she wishes to comment.
Yukti, are you there, Dr. Yukti?
Yeah, good afternoon, ma'am. Good afternoon, seniors. I'm there, ma'am. Yes, ma'am.
So do you want to comment something?
Ma'am, it was an excellent discussion, but I just wanted to know about the post-op suppression with the GnRH agonist. How much is it recommended and how much is it useful?
Doctor,
Jyoti, you are muted. Jyoti, you are muted. Please say it again.
So what I was saying, but that is what the HT guidance is. After a surgery, everyone would recommend that once you have done a surgery, then you help her to get pregnant as fast as possible.
As fast.
So there's no role of gynecologist.
Yeah. What we have been doing till now is, that once the eggs are preserved, we give them a GnRH analog, one injection, second injection, and then we subject them for ET. I find that the results are great. Previously, they were not good. And this will be our absolute 360-degree change, what Dr. Jyoti Bhaskar says.
And what about before going for ovarian stimulation?
Ma'am, the HT says about the giving GnRH agonist before stimulation. He says before stimulation, there's no rule of giving it, but before ET,
that is
definitely they say that can be done before doing an ET. But for stimulation, he says do not recommend.
Doctor, मेरा अपना पर्सनल एक्सपीरियंस कहता है जब से हमने फ्रेगमेंटेड IVF शुरू किया है एंडोमेट्रियोसिस के लिए और एडेनोमायोसिस के लिए. Adenomyosis में तो I don't believe in 2, I believe in 3 injections, and I find 50% of time she's pregnant और उसके हमारे पास embryos पड़े ही रह जाते. Or secondly is that as far as endometriosis is concerned, because her reserve is less, we take the eggs and we make the embryos and freeze it, and then we definitely give a GnRH analog.
Ma'am, that's what Aisha is also recommending. That do not for stimulation, do not before that give.
No, we don't, because doctor, you can't wait. Uska to already reserve kam hai.
Ma'am, they say that's the same thing.
Dr. Poonam, this is Dr. Anita. You had given a hypothetical situation in which the patient was operated, and then she said that she's not willing for, she's not socially prepared for conceiving right now. So, won't it be a better idea that she should postpone surgery unless there is a pressing issue of severe pain or something like that? So if she is not yet ready, so it will. I think it will be better that she, postpones the surgery also if there is no pressing issue like pain or severe.
She must have been exposed to surgery because of pain only. For IVF, no one is.
Yeah, that is what I was wondering. Because we have to give a good counseling.
Because I feel, children who start with endometriosis early, I find, one surgery and then they go somewhere else and then they have a second surgery. And whatever they try, unka IVF भी fail होगा, सब कुछ fail होगा, and they'll end up in hysterectomy at 35, 34. They have a miserable life. I think, Brigadier Sharma and Madam Dinesh Kansal and all can comment on this.
Dr. Adita, this patient can be put on Dynogest also after surgery if she is desiring to postpone the fertility.
Okay. Sir, Dr. Sharma, what is your what is your consideration of IVM, sir? Is there any role, or we should just keep it aside? In vitro maturation, sir. IVM.
IVM, yeah. The thing is, the IVM should be done by the experts who are doing it regularly. It is not that easy because I have done a research project when I was in Army Hospital, R&R. And, you get very good, expansion of the corona. You can see the compact corona, expanding in front of you, say within 14 hours or so, and then you do the ICSI for them. But the thing is, it should be done when you're doing it routinely. Just because, it has come in the news and you want to do the IVM, it should not be done. And because there are 2-3 problems in that. One is that doing the ovum pickup, when the follicle size is very small, and especially when the ovaries are very mobile. So you may create more injury to the gut next door and create more problems. So the ovum pickup firstly is a big challenge over there. Okay. And the second thing is then in vitro maturation, the amount of SCG to be added in the culture media and all to maintain the osmolarity and all, you should have osmometer properly, so that you do not change the osmolarity of the culture media. And then doing the, you have to do the ICSI, well, that is a common thing now, and then freeze those embryos and use them later on. So it is a dedicated work which should be done by a center which is doing routinely, IVM. Just one case you are doing in 6 months, and so I think that will not give you the results.
Anita, ये theory है, खाली theory है.
हाँ, बिल्कुल theory है सिर्फ. So, Dr. Surendra Sharma, he has asked that has anyone seen endometriosis in 12 to 13 years girl? Yes, once the periods start, there can be endometriosis, or there can be endometrioma. And another person has asked how to diagnose tuberculosis in endometriosis, from where to take the tissue. If you are doing laparoscopy for any reason or surgery, and then you can take the peritoneal fluid or tissue from the peritoneum or the cyst wall you can send, and otherwise endometrial tissue you need to take. So I think, ma'am, we can conclude the session.
Absolutely great, superb.
Thank you. Thank you so much. Thanks to my...
Thank you, Dr. Dinesh Kansal. Thank you very much.
And special thanks to Dr. Dinesh. He specially spared time for us. And special thanks to all the delegates who joined. We had 80 plus attendance today, and that was great. Thank you so much. Thank you, Malti.
Thank you so much. Thank you, ma'am. Thank you, sir. Thank you, everyone.
Thanks, everybody.
Thank you.
Thank you. Sir. Sir के tips boss.